Have you ever had pain with tampon insertion, having a pelvic exam, sex, either insertional or deep penetration, wearing tight clothing, or even sitting? If so, you might be experiencing something called pelvic floor muscle overactivity, or you might have found or been told that your pelvic floor muscles are hypertonic. My name is Dr. Jocelyn Conley. I'm a pelvic floor physical therapist and founder of the Vagina Docs. And in this video, I want to talk about what it means to have an overactive pelvic floor. Now, just for terminology's sake, I prefer overactive pelvic floor versus hypertonic. And that's a personal preference, but you might hear providers say one or the other. Now, a person can have overactive pelvic floor muscles for a variety of reasons, and some diagnoses given by different providers might include vaginismus, vulvodynia, dyspareunia, coccydynia. It just depends. All of those diagnoses in some way relate to overactive pelvic floor muscles. Now, what are the pelvic floor muscles? Well, our pelvic floor consists of muscles, vessels, nerves, connective tissues, and for my sake, what I'm going to focus on today would be mainly the muscle tissues and the connective tissue that intertwines and supports the pelvic floor muscles themselves. And before I get into the rest of the video, I just want to review the muscle system or this area to give you some context onto what areas typically are overactive in some of the diagnoses that I had mentioned, and what to do about it. So the pelvic floor is a muscle group, and it's separated into 3 different layers. Layer 1 is what you see on the outside. Layer 1 muscles are what you see here, and then if I were to do an exam, it would be with about one knuckle inserted into the vaginal opening. And there's different muscles. There's these ones here, there's these ones here, there's the area between the vaginal opening and the anus, as well as across. And the function of these muscles are to support the clitoris onto the pubic bones here, and also give support to the vaginal canal that's within the pelvis, and connect the outer pelvic floor layer to the pelvic sidewalls, as well as the front half of the pelvic floor here and then the back half. That's layer 1. Layer 1 is typically involved in conditions like vulvodynia, vaginismus, versus dyspareunia. It's the deeper layers, which I will get into in a moment. So let's say I could remove this and you were seeing just the same thing, but maybe just a sheet of connective tissue and some muscles. That's layer 2. Layer 2 from a physical exam is a couple knuckles deep, and it's another layer across here, as well as 3 muscles surrounding this opening here, which is the urethra where urine comes out. And then, of course, a deeper layer back here just deeper to the external anal muscle, which is called external anal sphincter. It's the internal portion. Layer 2 also houses a lot of connective tissue. Connective tissue is just reinforcement of the structures within the pelvis, as well as the muscle system, and it really helps connect the right side, the left side, helps connect the pelvic floor to your hips and above and below. Now, layer 3 is 3 knuckles deep, and it's a muscle group. It's anywhere past 2 knuckles and then further. Muscle group that helps really provide support for the pelvic organs that include the bladder, uterus, the ovaries, the fallopian tubes, and the rectum, and supporting ligamentous structures. Layer 3 is also part of the deep core. The layer 3, while also when I am examining the muscle system, I also look at other muscles that are within the pelvis that are not formally considered pelvic floor muscles, but help stabilize your sacrum here, your tailbone, as well as our hip stabilizers. Layer 3 has really key areas where one of the nerves called the pudendal nerve can get caught or restricted, and that could be somewhere here. It could be, this isn't the easiest place to see, it could be somewhere deep here or even further out here or above. And that can also be part of overactive pelvic floor muscles for whatever reason. So let's dive into what is going on. Like, why is this happening? Well, you can have overactive pelvic floor muscles just because of the muscles and the nerves themselves. They're tight for whatever, maybe you had a trauma, maybe you just, the area that you tend to guard or tighten when you're stressed or overwhelmed is your pelvic floor muscles or lower abdomen muscles. It could be they're overactive because your glute muscles, inner thigh muscles, they are overly tight, whether that is a habitual thing or it's because it's related to your work or your sports or just your everyday life. Or maybe it's because your joints, your hip joints or your spine is more on the increased flexibility. So your pelvic floor tends to contract more as a way to add stability to your pelvis and your hips. Those are musculoskeletal or neuromuscular reasons where your muscles might be overactive. One other key reason could be because you're constantly guarding your abdomen or you're not breathing fully through your diaphragm. What that looks like is your breathing stays up here. So if I tell you to take a deep breath and you're like, that could be, well, what happens there is instead of your diaphragm fully moving downward and as it moves down, pushing your pelvic organs down, that time, and when it does that, your pelvic floor elongates or stretches to control that elongation. Well, if that's not happening, the pelvic floor can actually be pulled in more into a more tightened position. And believe it or not, many of us do that more than we think, both at rest and during exercise. So just simply breathing the same way or talking in a way that our abdomen goes in every time, or even talking up here in a really shallow voice, that can create an overactivity situation in your pelvic floor muscles. Now, I will say, based on my experience, I don't often see one thing being the case. Typically, there are a lot of things that compound on one another. Let's say we have an athlete or a person that's active with a history that, say she played soccer and she got kicked quite a few times between the legs, or she had a labral tear, or she was a dancer and was told to tuck her pelvis under so that she had this more upright posture. In that case, she had a hip injury or dealt with different injuries in her leg, as well as maybe she fell. Maybe the person had a motor vehicle accident and a couple of whiplash injuries. So it's hardly one instance. It's hardly just it's your breathing, or maybe it's you're super tight because of your workout program. There's usually multiple different things that are happening, or maybe it was a stressful childhood. Lots of different things. But let's talk about when it's not mainly from movement or the muscles and nerves themselves. Let's talk more of other drivers. Common drivers of pelvic pain conditions could be GI driven, so gastrointestinal, hormonally driven. So common things that come to my mind would be a subtle issue going on, maybe you don't even know about it, an inflammatory reaction in your belly or somewhere in your intestines. And it might not even be functionally super limiting to you. Maybe you were just told that you have IBS, or maybe it's, you have a few food sensitivities. Typically, the presentation in the pelvic floor muscles, particularly the ones on the outside. They are sensitive to fluctuations in our hormones. Our gut is a key place that influence our hormones. The other areas would be, we think of our thyroid, or our doctor says thyroid. We think of our cycles, our fertility, ovulation, menstruation, and we also think potentially other things depending on your background and expertise. Now, when we talk hormones from a gynecological standpoint, the first thing that comes to my mind that I see often is issues like endometriosis, ovarian cysts, and fibroids, PCOS with ovarian cysts. Now, arguably, those conditions are endocrine versus gynecological. That's my own personal opinion about that. But the first person that typically that we go to would be our gynecologist. For if it were my daughter, I would look deeper than just blanket or band-aid the issue with birth control. But the hormone system, estrogen, progesterone, can also impact our pelvic floor muscles. So what we commonly see in pelvic PT is that there's a change around the cycle in their pain and their sensitivity and how tight their muscles present, and not or how flexible they may present. There is a study that I had stumbled upon, this was years ago, where it showed cellular changes in the outer pelvic floor area from long-term birth control use. So that needs to be explored more, but there is definitely a hormonal component with these pelvic pain conditions, particularly related to the outer layers. Now let's talk about other drivers. Why could someone experience pelvic pain, whether it's the outer layers versus the inner layers? And some things that we see in the clinic are related to restrictions around the bladder. So inflammation around the bladder, one common diagnosis would be interstitial cystitis. With that, I typically see pelvic pain conditions, general pelvic pain or abdominal pain or even dyspareunia versus the other diagnoses like vaginismus, vulvodynia, those two being like insertional pain, can't really tolerate any sort of penetration or very minimal, or that's the bigger issue, versus depenetration. Symptoms, pain with sitting, issues with clothing and other things related to the skin. So I touched upon primary drivers being musculoskeletal, neuromuscular. I talked about other things like hormones related to GI or the gynecological system or elsewhere. So if you dig deeper, you can maybe it's related to thyroid or the other major hormone producers in our body. And then also talked about, I believe I just mentioned the bladder. Anyways, what do you do about those things whenever when our physiological systems are acting up and it's presenting as muscle problems? Well, pelvic PT is still beneficial in that case. However, also addressing the other things is part of it as well. Now, any trauma can impact the first camp, so musculoskeletal that I talked about, neuromuscular, can also affect the second camp and be a driver or part of it of the hormone system and other physiological systems acting up. So it's important to have a multidisciplinary approach in that case. What do I do to help with all of this? Well, part of what I do is I try, if it's a primary problem with your musculoskeletal, neuromuscular system, posture, and so on, we focus on that. let's say if it's the other stuff that I mentioned separately, well, I, along with other members of your healthcare team, should be working together with you to determine what is the driver. A lot of times it's things related to our diet, our stress levels, how we're coping with stress, how much we're exercising, how much we're refueling, how much we are staying away from inflammatory drivers such as food, drinking, anything along that. Sometimes we have to identify our sensitivities and try to work around that. But then one part that I really love what I do that supplements that, because let's say your body isn't really receptive to all the water you're drinking or the healthy diet. Well, we address your fascial system. So your fascial system is a type of tissue in our body that supports everything from the muscle itself to individual fibers down to cells, in fact every cell in our body. And when there's trauma, whether it's physical or an emotional trauma, the fascial system can be restricted, and that impacts the ability for the cell to take in the great stuff that you're putting in. So prolonged stress can restrict your fascial system. Injuries, surgeries, just not moving, not exercising, or exercising too much can all affect the fascial system. So typically people respond really well with myofascial release, an approach that myself and my colleagues also utilize with people that have these conditions. And sometimes it takes time to get here, to do any internal work here, to improve flexibility here. We have to actually work from the outside in, and oftentimes improving abdominal wall mobility, your back mobility, your hips, and then maybe it's stability in the case if you're really mobile. That can really impact your body's responsiveness, and then we can move forward to the internal work. So in summary, in this video, I talked about why the muscles are overactive, different reasons, different diagnoses, and then I touched upon approaches. I touched upon layers, how different layers can become overactive, the outer layers versus the inner layers. I talked about some of the nerves, some are out here, some are deep within the pelvis, that can impact overall presentation. And then I talked about different reasons why your pelvic floor muscles might be acting up. It could be primarily the pelvic floor muscles, or it can be elsewhere that's resulting in overactivity in these muscles. I know I covered a lot, so if you have any questions, please place them in the comments below. If you thought this was helpful, press the like button, and if you want more content like this, all things pelvic health, be sure to subscribe. And then if you know anyone that can benefit from this information, share this video with them. So that's it for this video. I will see you next time.